Welcome. I know we have a robust presentation today from one of our newest faculty members. And speaking with him today, he started July 20th, so very new to Pittsburgh, very new to the department, and a really, I think, timely and exciting topic. We're hearing a lot about AI, artificial intelligence, in healthcare and in many industries right now. And Pittsburgh is hosting a lot of symposiums on artificial intelligence this fall. So it's a really great presentation and we're excited for it. So I'll go ahead and get started. Thank you again for joining us. As you know, I'm Carrie Fogel. I'm the Senior Director of Development for Foundation Relations at the Ioneer Foundation. So I'll be moderating today's talk. Every month we host these in both topics in otolaryngology, so head and neck cancer, sinus, allergy, balance, and in ophthalmology, talking about blinding and conditions and vision loss and new technologies and therapies in both areas. So today's presentation will feature a discussion on AI and head and neck cancer with Dr. Steven Chinn. Before I introduce Dr. Chinn, I'll just remind everyone that we don't use the chat function as part of the Zoom webinar, but we can submit and take questions via the Q&A box at the bottom of your screen. I'm going to hold all of the questions for Dr. Chinn until the end of his talk, and then we'll moderate a Q&A session. So feel free to submit them at any time during his talk, and I'll go ahead and make sure that we ask him at the end of our time. If it is something very personal related to your health, you should absolutely ask it. I may not ask the question live, but we will certainly send the questions over following the webinar to Dr. Chinn, and he can answer them offline, and we'll get an answer emailed over to you. I also did want to say that coming up in September, on September 10th, we're having a panel discussion in some topics in head and neck cancer about emerging therapies and kind of new treatments on the horizon. It's an evening in September 10th from 5 to 6:30 p.m. It's kind of a social way for it, but also an educational opportunity. And Dr. Chinn is one of our speakers, in addition to Dr. Jose Zavallos, our chairman, Dr. Matt Spector, and Dr. Kevin Contreras. So I'll just plug that as well. If you are interested in attending, you could submit a question to the Q&A box, or you can reach out to any team member at the Ioneer Foundation, or you can respond to your email from your webinar, and that will let us get in touch with you as well. So all that behind me, let me go ahead and introduce our speaker today, Dr. Steven Chinn. Dr. Chinn is an associate professor with tenure in the Department of Otolaryngology, Head and Neck Surgery at the University of Pittsburgh School of Medicine and at the Hillman Cancer Center. He's also the co-director of the Hillman Cancer Center Head and Neck Cancer Program and director of research and clinical operations for the Computational, Pathology, and AI Center of Excellence at University of Pittsburgh. Dr. Chinn integrates a high-volume, complex surgical practice with multidisciplinary care and translational research that merges clinical trials, computational spatial analysis with artificial intelligence, and multi-omic profiling to individualize therapy and improve outcomes for patients with head and neck cancers. Apologies for the background noise. Nationally and internationally, Dr. Chinn is an active leader with clinical trial development and translational research, and has led multi-center phase 2 and phase 3 trials that integrate advanced imaging, response-adapted surgery, and biomarker-driven patient selection. So that's all really impressive. Excited to have Dr. Chinn with us on faculty now and hear kind of what he has to say about AI and head and neck cancer. So I'll go ahead and turn it over to you, Dr. Chinn.
Well, thank you, Carrie, for the invitation to kind of talk about an area of technology that is near and dear to my heart. As you mentioned, I am the director of research with Computational, Pathology, and AI Center. And really, that's what we're trying to drive, integrating artificial intelligence into healthcare. And so I kind of want to talk today a little bit about, how we are trying to do that. In terms of disclosures, I am on a medical board for a company that's not related to AI, and this is my research funding from the NIH that is integrating some of the technology that I'm going to talk about. I always give this kind of picture, we talk about AI. This was actually something I generated talking about non-disclosures back in 2023, and it gave me this funny kidney. And when we look at what we're able to do with AI in just the last 2 years in terms of generative AI or image making capacity, it is dramatically changed, and just shows what we are able to do. But just in terms of a little bit of background, just for those who aren't as well versed in head and neck cancer, head and neck cancer is really defined as any cancer by which the area that it came from. So whether it's skin cancer on the face, throat cancer, mouth cancer, ear cancer, those are all things that we deal with within the head, neck, thyroid, salivary gland. Specifically, though, and what I'm going to mostly focus on today is something called squamous cell carcinoma. And squamous cells are really the lining of your mouth, the lining of your skin. And those are really the most common types of cancers that we treat as head and neck cancer surgeons. However, within the US, they're fairly rare, really only 3% of all cancers, but they are quite, morbid. And in terms of survival, it's not very good. What we traditionally see is that our cancer patients are smokers or drinkers or tobacco chew. If you're from Southeast India or Asia, chewing on betel quid, which is kind of a cultural risk factor, has also led to high rates of mouth cancer. But also there's been a recent epidemic of human papillomavirus causing tonsil cancer and base of tongue cancer. And again, all of these have led to kind of an increase in terms of the number of head and neck cancers that we have to deal with. Again, though, I always like to show this map when we talk about smoking-related cancers. I was formerly in Texas for my fellowship, and then in University of Michigan, and now in Pennsylvania. And so for my line of work, being kind of near the smoking belt, which is in that dark blue, unfortunately leads to a lot of head and neck cancer patients. But head and neck cancer affects everyone. And this was, a slide of different celebrities, musicians, athletes that have had, and many of which have died from head and neck cancer. Tony Gwynn, the great baseball player, Adam Yatch from Beastie Boys, Gary Busey, Val Kilmer, have all had head and neck cancer. So it doesn't, pick one area of society to target. And that's why, it is an area that we need to focus on. Like I mentioned, head and neck cancer is actually quite deadly. And in the last 75 years, we've seen some improvement of survival. And this chart shows, from 1950 to 2020, we've had an improvement. But I would argue from 1990 to 2020, we haven't seen that much of an increase in terms of our ability to treat this cancer and successfully cure people. And these are just some photos, and I apologize for the graphic nature of them, but this is, some of the cancers that we have to manage. And unfortunately, we cannot, cure everybody. And that's why we are trying to figure out better ways. I always liked history and thinking about where have we been and where are we going. We've been trying to study cancer since 3000 BC with the Egyptians. Hippocrates back in 400 BC eventually coined the word carcinoma. In the 19th century, the light microscope enabled us to look at, cells. Watson and Crick identified DNA back in the 1950s. And I'd argue in the early 21st century, we were able to really dive into cancer, looking at the DNA, the RNA, the genetics, and really get a better understanding. But I think we're now transitioning into the next phase of cancer discovery, and that I think will have a major component from artificial intelligence. And so why do we need AI in head and neck cancer? And really, it's simple for anyone who looks at cancer, studies cancer. Cancer is very complex. The biology, the different treatment options, and more importantly, the outcomes. I tell patients, I tell my residents, I tell my fellows, it's also a huge information overload. Patient data, clinical data, whether it's your imaging, whether it's your pathology. If we want to go into sequencing your tumor, that gives us huge amounts of data. And really, the way I view AI is that it's an assistant to help us make sense of it all. Like Carrie mentioned, AI in medicine, you open up any newspaper, any magazine article, and you will see something new with AI that is coming out. And that just tells us just how important this concept can be and why we really need to understand it and harness it, for good, and in my case, for treating cancer patients. Just like I like talking about the cancer discovery history, the history of AI goes back to antiquity. Really, it was the Turing machine in the early 20th century that laid the groundwork for artificial intelligence. The Dartmouth Conference in 1956 termed artificial intelligence. And then it wasn't until the late 2000s where we were able to harness our computational power to develop these new AI algorithms that we're starting to see today. But what is AI? And I think this is an important concept to understand. AI is a machine's ability to perceive, synthesize, and infer information, and then perform a cognitive function associated with the human mind. And really, that's what we're talking about, is allowing these systems to think and process information much like we do as humans. But again, I've had 47 years of life experience to develop my brain. And so the question is, how do we train these machines to do that? Traditionally, we would program a computer to do something. Most of our computers can do that. I type in something, it will do Y. But what AI and machine learning do is it actually not only can do it, but it learns from the data. For anyone who's a parent, that's how I think about it. You teach your children by multiple examples. In the case of my two children, sometimes one of them needs more examples to learn something. But when they're little, saying that is a cat, you have to show them multiple different cats and how do they differentiate that from a dog. But it's the data and them learning over time that ultimately allows them to then think independently. And so that, in a nutshell, really is what AI is. It's taking large amounts of data, training the model to then make decisions based on what it learned, just like what we do as human beings. And so why does it matter? Well, it impacts all of our lives. Really, almost everything we do at least has some level of artificial intelligence built into it, whether it's your smartphone, whether it's your car, some of the automatic braking, some of the steering components. That all is artificial intelligence. Obviously, social media platforms, navigation, e-commerce, banking, the financial sector, they're all using these AI components built into it. And when I talk to a lot of people, they're always like, oh, well, is AI going to take over? I don't believe that it will. I think that it will become a part of our everyday life to make tasks faster and easier for us to then focus on tasks that the AI can't necessarily do. But diving in a little bit further, within AI, something called deep learning. And I want to kind of spend a little bit of time talking about this because this is important when we think about some of the research that I'm doing. So deep learning is a subset of machine learning. So machine learning is you train the machine to do something. In deep learning, it uses neural networks, similar to how our brain works, and thinks about, what is information that goes in, it then processes it on multiple different levels. Again, thinking about how a child learns from a parent and from teachers. It can then extract kind of features from the data that you're giving to learn over time. The example I think about is when I was teaching my son how to walk. I taught him how to walk on a nice flat carpeted surface. He eventually learned how to walk. We ultimately would take him outside, took him on a hill, took him on hikes in the mountains. I didn't specifically tell him, you're on a hill, you need to think about the slope to, how do you adjust your foot? He was able to learn that over time and through experience. And that's a lot what these neural networks are doing. But again, you need a lot of data to train these models. Some of the examples are, like I said, the driverless cars, Alexa, and the Google Home component. Another way to think about it is you give it input, it goes into the model, it extracts features, And then it's able to say, this is a car, this is not a car. Again, this is a pretty basic looking car. It has, at least can see two wheels, has a windshield, a side mirror, some doors, that's a car. This is a funnier looking car, but most of us would call this a car. But again, to train the model to identify this relative to the first one, it takes time and data. And then the final one would be this thing, which my son calls a refrigerator on wheels, but it technically is a car. But again, to train a model to say, yes, that is a car based on what that looks like, it would take a lot of data to understand that. What about in medicine? AI has been really integral in academia since the early 2000s. This chart is showing that back in the early 2000s, the vast majority of AI models were developed in academia. However, over the last 20 plus years, industry has really taken over as leaders in terms of AI technology within healthcare. But roughly around 10% are still a combination of the two. And so again, as a physician, as a scientist, I have to be aware of where is the technology moving and who is driving it. Because it is important. You have to think about some of the pitfalls that are associated with artificial intelligence. Like I kind of mentioned before, it requires a large amount of data to have accuracy. Is that data available? What is the quality of it? And is it generalizable? What does it mean if we analyze patients only in Pittsburgh? Does that actually mean we can then use patients in a totally different state and get the same outcome? Probably not. And so those are some of the challenges. There's also some technological limitations. There's something called the black box, where that neural network, we actually don't always know exactly what is going on. And it will spit out an answer that we don't know what it derived that answer from. And some of the interpretability and also hallucinations. Some of these models can actually spit out answers that make no sense and are not really derived from any rational, data at all. And those are things you have to think about. And then scalability. Can we apply this broadly and can everyone use it? And like I said, a lot of these models are built on simulated data and not real world data. So again, how much can you trust it? And it really goes into how the model was developed. And obviously we have to think about ethical concerns, privacy. Really anything you put into any of these AI models on the web is not going to be, protected. And so a lot of institutions like University of Pittsburgh, have our internal AI models that are not accessible, to industry per se, but also biases that can come from it. And I think this is something as a surgeon I have to think about, the negative impact on the doctor-patient relationship. If we are using AI more and more to answer questions, right? What does that do to my relationship, with the patient? Obviously, we have to think about regulatory issues, and how they're being used safely, and what is the efficacy and how good is a model that's being put out, for public consumption. And this all takes time and effort. And again, I think when I talk to colleagues and I talk to patients, I think there also is that clinical trust. And one of the ways that we're able to do this is you need to have a human-centered design where humans and physicians and scientists are actively involved with how these models are developed so that we can trust their accuracy and their utility, particularly when we're talking about healthcare. Now, how can we use it in cancer? We know that it has great potential. And a lot of work has been done, not just in head and neck cancer, but in breast cancer and prostate cancer and GI and colon cancer, looking at screening, looking at diagnoses. Can we predict how well somebody is going to do versus, man, you have a bad cancer, maybe we should give you more. What type of treatment should we give? And can it help design the treatment that you're going to be getting? And then surveillance, can we use it to follow you, right? Is the cancer back? Is it not back? And then can we use it in survivorship? And the people that survive their cancer, they have often a lot of side effects from some of the treatment. Can we help mitigate some of those and predict who needs more intensive therapy or who is doing okay, or when to identify early when issues are coming about? And I have a couple examples of some of these, and this is, talking about radiology and imaging. And so this is a chest x-ray. And actually, this is where some of the field has been very, successful, is identifying nodules based on a chest x-ray. Anyone who's looked at a chest x-ray, I would have looked at this and said, yep, that's very normal, and missed, the centimeter nodule in the right upper aspect, right in this general area. But we're able to train these models to pick up subtleties that the human eye can't necessarily pick up. And again, this talks about some of the advantages of using artificial intelligence in healthcare, and particularly in cancer. Here's another model where they're able to use imaging to then identify how people are responding to the radiation therapy they're getting. And that helps us then say, you know what, that tumor is regressing and getting smaller. Maybe we can give a little bit less radiation, or you know what, that's a bad looking cancer based on the model. Maybe we should give more radiation. So again, assisting us to develop better plans to help patient care. I think one of the other areas, where we have a lot of utility for using artificial intelligence is in clinical data. All the data that goes into the electronic medical chart, in theory, is accessible to researchers and allows us to aggregate all of this data to start developing models to predict outcome, personalized risk scores to say, you have a really good chance of surviving versus, you know what, we're a little bit more worried. Or using it for symptom management. Again, all this data can be inputted. You can plug in on your phone, I'm feeling good today. But over time, it can track how you're feeling based on what you're typing in, and can say, you know what, we're worried about patient Y because they have started to have a downward trend, and then have a nurse or one of your physicians call you and check on you. Again, these are ways that big data can be used using AI models to help integrate into cancer care. As Carrie alluded to, I do a lot of omics or sequencing, looking at RNA and DNA within cancer. And this is some of the work that some of my colleagues and I did when I was at the University of Michigan, where we're able to take an entire cancer and then deconvolute it or deconstruct it using an AI model to tell me what is in each cancer, what type of cells, were in this cancer versus that cancer, and then start to understand what is making up the cancer biology. And by doing that, helps inform us what is going on and how can we better treat them. And then this is work by a colleague at the University of Chicago who was able to use some of the slides that are routine in cancer care and identify gene mutations, which typically involves a very costly and time, intensive effort to identify these mutations. And they were able to show that they could do this looking at just a picture of the cancer, a slide of the cancer alone. And that saves time and saves money. This was in prostate cancer, but, again, demonstrating some of the power that, AI has in cancer therapy. And then finally, this was a study that looked at using artificial intelligence to drive adaptive radiotherapy. Again, looking at the tumor, is it shrinking, developing a plan based on what the model is seeing to optimize care. And they were able to show that they were just as good as radiation oncologists in developing some of these plans. Again, in a very select group of patients. But again, this demonstrates some of the power that artificial intelligence has. One of the things I think is the most exciting that we haven't gotten too far into yet is something called digital twins, where I can take an individual patient, integrate all that data that we just talked about, whether it's their clinical data from their charts, whether it's their x-rays or CT scans, patient symptoms, questionnaires. Maybe I can sequence their tumor. Maybe I can look at their pathology. And then we can then make a digital twin or a simulation of that exact person. And then we can run different models saying, if we do X, if we do Y, what do we think will happen? Will they respond better to this treatment, or will they have a better side effect profile? And this is where we're starting to look at how can we integrate these digital twins into clinical trial development. Is it possible for us to, instead of enrolling 500 patients, which is costly and time expensive, to actually use a smaller group of patients and get the same answer. Again, we are still very early in this, but this is some of the work that we have high potential for. But that's kind of what's been done, is being done, in the cancer field overall. And I wanted to kind of talk a little bit about what my group and CPACE is doing here at the University of Pittsburgh and at Hillman. And really what we're doing is developing AI models to improve how we diagnose cancers, how we can identify how well patients are going to do. And some of the work I'm using is something called digital pathology. We take a slide of patient's cancer, we digitize it with high resolution, and then we're able to let our algorithms look at it and then identify what we call biomarkers, or ways for us to identify how you're going to do. And then we're integrating that with that DNA and RNA evaluation to start to understand tumor biology, to see if we can come up with better treatments for patients. And then what I think is most exciting, what we're looking at, is something called predictive tools, where if you have certain characteristics, we believe that you will respond better to a certain type of treatment. Obviously, this is a collaborative effort with my team, CPACE, computational biologist, biostatistician, and bioinformatics. But again, this is very exciting, some of the work that we're doing. Specifically, we're looking at the role of immunotherapy in head and neck cancer. So for those of you who don't know, immunotherapy is one of the newest kind of therapies that we have to combat cancer. And what it does is it activates your immune system to actually fight cancer. And the chart on the left basically shows over the last 20 plus years, there's been an explosion of immunotherapy trials across cancer. One of the challenges, though, within head and neck cancer is that if we give immunotherapy to everybody, only about 20–30% of people actually have a good response. And so that means the vast majority of people aren't deriving this benefit from immunotherapy. And so what we believe is that head and neck cancer, and this is just a cartoon of cancer, has very specific makeup, the different cells, the blood vessels, the organization of it. And how do we untangle this to better understand why does it not respond to the immunotherapy, and why can we not improve those patient outcomes? The analogy I like to use is my son's bedroom, and my wife is mortified when I show this photo, but cancer is a chaotic kind of environment. Multiple different cells, kind of different types all over the place. Much like my son's room, or the picture of his toy closet on the right, it's absolute chaos. You have stuffed animals, Nerf guns. I don't even know, what is in that room. And we have that kind of same, understanding of cancer. There's a lot of unknowns and a lot of chaos. And so how can we better investigate that? And so, like I said, we were able to use some of these AI models to deconstruct the cancer and say, in this particular cancer, we know what type of cells were in that. And the analogy is, in my son's room, I could run the same algorithm and say, oh yes, he has a bunch of stuffed animals. He has X number of toy robots, toy soldiers, Legos, Nerf guns, etc. And so this is kind of how we are starting to deconstruct the cancers so we can better understand them. The reason why that's important is when we think about head and neck cancer, we talk about them being either these immune deserts or wastelands where they don't have a lot of immune cells. And those are typically the ones that don't respond to immunotherapy. Whereas there are others that we call immune oases that are, we call hot and very responsive to immunotherapy. And so again, using these tools, we can start to better classify how these cancers are developing and possibly how can we change it. And that's really what we're trying to do, is from the bench to the bedside, is how do we predict what type of cancer you may have. Is it that cold wasteland, or is it the oasis? But more importantly is, how could we change one of these kind of desert, kind of non-responsive tumors into a much more favorable tumor that would respond to immunotherapy? And that's something called immune modulation. We're actually changing the cancer's environment to make it more responsive. And the reason why this is important is we don't necessarily know with current data what tumors are going to respond. There are some markers that have been developed and they're FDA approved, but they're not very good. And that's because cancer is complex. You can have some tumors that just get bigger no matter what you throw at them. Some will do kind of okay, but slowly grow. Other will initially respond and they get worse. And then others will actually have a good response. But how do we identify which ones those are? And like I said, there are multiple different, markers that we've developed, but none of them have been all that great in terms of predicting it. One of the kind of caveats is they're just looking what's in the tumor, and they're not necessarily looking at where those components are within the tumor. So just like my son's room, if I think something smells really bad, I'm not looking at the Legos. I need to look at the dirty sock, or the pizza that he left there for a couple of days. So again, understanding the spatial aspect is actually really important and one that hasn't really been fully looked at. And that's what my lab is looking at, where we're taking digital pathology. So here's a cancer. We're able to create a slide that the pathologists look at it. We then digitize it at high resolution. And then we integrate some of these neural networks to start to understand and comprehend the spatial aspect. And this is some of the work that we are, publishing and have a couple of grants looking at, where we have a slide. We can then look and the computer can identify the different cells and then label them and then look at the relationship of the cells and how people do. And by doing that, they actually can predict if you're going to survive or not survive at pretty good accuracy. And these are just some real world pictures of some of the data. Just for any pathologist, this is the cancer. And then these are kind of like non-cancer cells. And again, the blue is cancer. So again, it's very good at identifying these cells and then looking at the spatial relationships. And we were able to show that when you had a high amount of immune cells that were really close to your cancer, people did really, really well. And whereas people that had low levels of immune cells or were far away from the cancer, they didn't do really well. And that tells us that the spatial aspect is really, really important. And we're able to run this from looking at a very standard slide that any laboratory, can do. And we can do this in under a second. So again, a very powerful tool for predicting how people are going to do with their therapy. We're also using it, to start to understand the cancer by integrating the pathology, the digital pathology aspect with the genomics and the transcriptomics and the proteomics, looking at the actual molecular components of the cancer, and then integrating that with the computational biology and the artificial intelligence. And through that work, we're able to kind of understand what is going on. But remember, I spoke earlier about that black box. And really, what we need to know is what is happening. How did the computer look at this and then tell me who's going to do well in the blue line and who's not going to do well? What actually is in there? And so we've often said this, if you have Alexa or Siri, is why did you do that? And that's some of the work that we're doing also, is looking in that black box, opening up the box and starting to understand why cancers are behaving in certain ways and what is driving the neural network scores. And this is something called explainable AI, or XAI. We actually go into the black box and start to uncover what is driving the decisions that ultimately led to the output. And by doing that, we've started to identify really interesting parts of cancer that may be driving whether the tumor is hot or whether it is cold. And by doing that, I can then target those areas to, again, immune modulate the cancers, to enable us to develop better therapies and to make people more responsive to the drugs that we have, or develop new drugs that we don't necessarily have. We're also looking at, and this is some of my NIH grant work that we're doing, is trying to identify precancers. And how can we take a precancer and know, is that precancer going to convert into a cancer? And in a similar model, we're looking at the digital pathology. We're looking at clinical pictures and can we stain it in the mouth with certain sprays, and then looking at CT scans or x-rays, but also looking at the DNA and RNA and the molecular components of it, looking at those different data points, plugging them into the model, and starting to develop the ability to pick out what is it and what is the risk of it from turning from normal to dysplasia to cancer. And again, very, very important from a screening perspective. Again, this is all still very early in development, but I truly believe that it has very powerful implications in terms of cancer care. And when we think about future directions in cancer, early detection and screening, like I was just talking about, personalized treatment planning, predicting treatment response, real-time surgical and clinical decision making. Can we develop cameras that can look at an area and say, that's an area that looks like it has cancer, even though it's not obvious, and I should then remove that. Again, we're using it for radiation, using it for drug discovery and for clinical trials. And just like in all cancer, there are also specific areas within head and neck that we can use it for. Discriminating the different types of head and neck cancer, whether it's HPV positive or HPV negative, different types of salivary gland cancers, which are very difficult to look at under the microscope. Again, can we increase therapy in people who need it, or can we decrease therapy in people who don't need it to try and minimize long-term side effects? Can we predict those side effects and identify better ways to identify patients who need increased therapy for recovery, or maybe who are doing really well on their own and don't need as intensive therapy? Again, more personalized methods. And as a scientist, can we decipher cancer biology? And I think this is where I'm excited, because that enables us to identify new targets to go after the next generation of treatment for cancer patients. So again, AI enables smarter and more tailored care, but really success depends on the data quality. You have to have good data going in to get good outputs coming out. We have to think about the ethical design and really how can we integrate this into clinical workflows. If it's too complex, that is not feasible to be done routinely in clinics. And so that is one of the areas that we have to really think about. Obviously, this is not work that I've done, by myself. I have my entire lab. Arvind Rao is one of my computational biologists and collaborators who's been exceptional with this. Obviously, the Computational Pathology and AI Center of Excellence, who recruited me here to Pittsburgh, and obviously my funding sources who have supported the work that we're doing. And I will take any questions. And like I said, as I am new to Pittsburgh, I have found this city to be absolutely gorgeous, and we are very excited to be here at Hillman. So thank you.
That was fantastic. Thank you so much, Dr. Chinn. I learned a lot, and I'm sure our audience members too. I actually think they did learn a lot, because we have quite a few questions, and I don't want to delay getting into them because I know some answers might be complicated as well.
Okay.
But I'll go ahead and get into it. So one question says, I know from personal experience with older family members that there's a lot of fear and uncertainty and skepticism surrounding AI. We hear a lot about it in the news, about, all over the media. So the question is, when working with patients, how do you explain AI on a basic level to perhaps an older adult? I mean, I guess you did that a little bit when you were talking about, but like if you're explaining to an older person in a clinical setting, how might you explain how you're using AI to help them with their managing their care?
Yeah, a lot of my patients who are in long-term surveillance, we get a CT scan of their chest once a year to make sure that they're doing okay. Unfortunately, a lot of patients have these nodules. I had that picture of the chest x-ray. But what I will show them is there's the standard way that I will look at a chest CT, and I'll scroll up and down with them and I'll say, okay, I think I see a nodule here, but I don't see anything else. And then there are other ways that radiologists have like made it easier to identify these things. And I'll show them that, right? Those are standard ways. And we now have these nodule collars that are AI generated. And I say, look, this one picked up the one I picked up, but also picked up one that I didn't pick up, right? And then I go back to the original CT scan and I say, oh yeah, I missed that one. And, again, that doesn't solve all the concerns, because I have concerns as an AI researcher, but it helps demonstrate there is utility. But I think also the humility of saying we also have to make sure we understand this technology, and we also have to have control and make sure there is human input. The hallucinations, like I said, are very real, and we have to make sure that we're controlling, for that. And again, I think that's where human oversight is really, really important. And really, a lot of the experts in the field still believe that, we're not going to have Terminator. I think a lot of us grew up with Terminator back in the early, in the 90s. I don't believe that is a true reality. But I think, you have to understand what is real and what is not real. And I think still having experts and physicians and nurses, look at the data to help make informed choices. So, and that's why I always go back to what I know and say, yes, I see that, or, you know what, I don't see that. We need to follow that a little bit better.
So kind of on that note, do you see AI programs informing things like robotic surgery, where eventually like a robotic surgery that's already kind of being performed, minimally invasively, but with the clinician at the helm, do you see AI playing a role in assisting or even performing some of these like
Yes.
robotic head and neck surgeries?
So AI actually already is helping us in robotic surgery. Yeah, a lot of people don't know this, but I don't think I have a tremor. But the robot actually, if you had a tremor, can actually control that tremor and slow down the motions of the arms. And also you can change the speed. If I move my hand really fast, I can make the robot though move much slower. So that is artificial intelligence that's at work already. Now, do I believe that I am going to be sitting at home and just tell the robot to do the surgery? No. I don't, I think there's too many variables, at least at this point. Now, in 100 years, I can't predict, the future, but definitely not in the next, I don't think within my career, lifespan will AI be doing robotic surgery without me controlling it. There's just a lot of variables that I think we still need to control. But it's already using, and it's very helpful.
So some questions that are focusing on data, because I think the data that we have access to at Pitt and at UPMC and at Hillman, kind of like having all of that medical data in our healthcare system is interesting when it comes to AI. So eventually, do you think that all patient data at UPMC will go into an AI database, or is it already in a database that AI can filter through? Like, how does UPMC and Pitt have this, the power to kind of hold all this data and then, use it clinically and in a research way to help someone like you who's doing research in AI and head and neck cancer?
Yeah, it's just like any other data. If I wanted to do a chart review and look at patients with tongue cancer, and we go through the charts manually and do that, I have to write an IRB and get permission from the Institutional Review Board of Research to say this is ethical and this is appropriate, and you have to set rules for what you're going to do. We have to do the exact same thing for our AI. I have to say, I want to use this data for this purpose. And the way I think about AI is it's just another tool to analyze data. I think, again, one of the concerns is that just all data is going to get plugged in to an AI calculator and whatnot. Now, that is possible if we determine that a AI calculator is very helpful clinically, right? And say, if you have X and Y and it's a tool, then I think it is possible, but that would have to be vetted at multiple different levels. It's just not going to happen overnight. I'm not going to do this tomorrow. It would really have to be, a system that has been shown to be very, safe, very effective, and have really good, rationale for using it clinically. But I do believe that that's where we want to try and go with some of this, because using that big data will will help us understand patient care at a much faster and efficient manner that I think ultimately will be better for patient care long term.
Thank you. We have a question that asks, will AI eventually help predict who gets cancer and who doesn't? Maybe,
And I mean, that's my, if you ask me what is my 20-year plan with my research, that would be it. Is how can we identify patients who get, head and neck cancer or cancer in general. Some of my earlier work was looking at these young women who get tongue cancer, and we ran DNA sequencing, we ran RNA sequencing, we did clinical data, and we really struggled to identify it with what we know. But in the back of my mind, I'm thinking about ways that we can integrate AI to help us predict these patients better and figure out why did they get it or who needs closer screening. So, I'm hopeful that we're able to do that.
So you talked a little bit about a digital twin model and
Mhm.
using a digital twin medical model in a clinical setting to help make informed decisions about, treatment, choices and all of those things. So do the digital twin models that you are looking at, that you're working with, they have all of the relevant imaging and all of the data, but do they also take into account social determinants data, kind of demographic data and other, maybe not like hard medical
Yeah.
data, but just like about the person as a whole? Do you take that into account, and does that change, the treatment pathway for some individuals?
No, and that's one of those, is it generalizable, right? And that's one of the challenges, because as human beings, it's not just I am a 47-year-old male, with X and Y, comorbidities who has this cancer. There also is, can you drive 2 hours to get to the center? What are your own personal biases? Did my uncle die of cancer and I never want to have chemotherapy? There are a lot of things that we can't yet integrate. And that's why, again, I don't think we're there yet where we say this digital twin is truly a twin, because I think that's a really good point. The social determinants of health drive who we are and drive our decision making, and also, probably some of the biology. So I think that's one of the challenges with the digital twin models. I think it's probably better in a population level analysis, but at the individual level, we're starting to play with it and see, where is it going to be useful versus where do we still need to work on.
We have a question about the your research specifically focusing on head and neck squamous cell cancer, carcinoma. And do you plan to kind of use AI to focus on more rare cancers, such as head and neck adenocarcinoma or any of the other more rare conditions?
Yeah, actually, I just met with one of our esteemed pathologists to talk about salivary gland cancers because of their rarity and the challenges with generating enough numbers, particularly adenoid cystic carcinoma. And can we identify, at the digital level, components that we maybe can pick up, with the human eye that better predict, response to therapy or risk of recurrence. That actually is one of the areas that we're looking at. There's something called generative AI, and we can create these synthetic databases. It's similar to a digital twin, but it really focused on just the cancer side of it to help better understand. But definitely rare cancers is another area that we want to further look at, because I think that is another strength that artificial intelligence has versus what we currently have, which is very little for a disease like adenoid cystic carcinoma.
Thank you. Do you think that the use of AI, a tool like, using AI would help kind of open up or democratize the clinical trial process when it comes to people being selected for clinical trials or enroll in clinical trials, being aware of clinical trials? There's a lot out there about people's access to clinical trials. Even they may be a candidate, but maybe they don't know about it. They don't have the internet. They're older. Do you think that using AI to kind of harness big data would help make clinical trials more successful, but also more accessible to individuals who might not normally, get to benefit from them?
Yeah, as a clinical trialist, I'll comment on the first part. Yes, I do believe that it will make clinical trials easier to run and, possibly use less patients. Again, could we foresee using big data and artificial intelligence to identify patients who maybe aren't in our system? Say, hey, you are at a totally different health system. We have a clinical trial here at Pittsburgh that we think you would be, eligible for, and you may, want to consider that. Then it runs into the whole, social determinants of health, and can you even get here if you live, somewhere else? But I do think it'll help us with clinical trial design. It'll help us with how we analyze data. Do we need as many patients per se? But getting people here is still, that's still a human problem, that I don't necessarily think or know of a way that AI can help. But like I said, that picture I showed at the very beginning, things change quickly. So never say never.
Well, I see we have a lot of questions, but several of them are more personal and some are kind of overlapping, and we may have already answered them. So I'll just ask one final question, and it's from an anonymous guest, but they want to know if you have had a permane sandwich yet from.
That is on my list of things to try. So I have unfortunately not. They got me working pretty quick as
Yeah,
soon as
I
I
was gonna say
arrived.
you're pretty busy. You've been speaking at different conferences that I've already seen you at just in the month that you've been here. So I think you just hit the ground running. So yes, I think as a new Pittsburgher, you must try a permane sandwich and let everyone know what you think of that. It's unique for
I
sure.
will do.
Um, so I think we'll go ahead and end it there. I want to say thank you so much, Ona. Thank you, Dr. Chinn, for spending the hour with us, kind of setting the stage for AI and head and neck cancer. I know that this almost could be like a yearly update about, your new role at CPACE and everything you're doing. And so we're excited to kind of follow along and see how things are going, and how you're growing your lab and your research here in Pittsburgh. So thank you. I want to say thank you to all of our guests who stayed on with us this hour. As you know, a copy or a transcript will be made available on our website. You can rewatch this webinar on YouTube and send it to people. It should be available in a day or so. And I will plug again the September 10th event at the Fox Chapel Golf Club. If you are interested in attending, please send a question to anybody on the team at our website, ioneer.org, or you can respond to your webinar invitation and we will make sure to get in touch with you. And I think that's it. So I'll just thank everyone, wish everyone a nice rest of your Friday, a good weekend, and we'll see you for the next webinar. So thank you to all.